Welcome to the practitioner webinar. This is Dr. Carol. The cases we're going to do today all happened in a 10-day period in Taiwan at the core seminar, and we treated 2 patients the week before the core seminar started. So the patients you're going to see during the webinar are Crohn's patient, and we took out the scar tissue, we repaired the gut. 38-year-old stroke patient with right-sided spastic paralysis, a Parkinson's patient, fibromyalgia from spine trauma. His name was Johnny. There's a fibromyalgia patient named Mr. Sung who had sleep deprivation, and then there was a burn patient who was burned over 40% of his body. So we'll go through those, and you'll get to see how you think about all these different cases and how you use FSM to treat all of them. Okay. Crohn's patient. Crohn's patient was a 32-year-old woman who was an occupational therapist. She had a Crohn's diagnosis at age 18, so she was, 14 years chronic, following an H. pylori infection. She was treated with antibiotics at the time, and that was important because we needed to make sure that the infection was gone. So that was an important thing. She had 3 surgeries at age 22, age 27, and age 29. Age 22, they took out about a third of her small bowel. At age 27, they took out, I think, part of her descending colon, and at age 29, they took out of her ascending colon. So she did not have a colostomy, but she had abdominal scarring that was significant. We didn't actually get photographs of her abdomen during the treatment. It would have been hard to see, but the scar tissue caused a ditch in her abdomen that was quite significant. She's been using an immune system suppressant infusion. I can't remember which one. It was the one that's really common, whose name is escaping me. Her last dose was 1 month ago, and she usually has the infusion every 2 weeks. She's an occupational therapist at the hospital, and the room was crowded during the treatment with PTs and OTs and the doctors in the hospital because this patient was very well loved. Usually the immunosuppressant is used every 2 weeks. She's now 1 month after the infusion, and she's not in a flare, so this was very encouraging. However, her symptoms were abdominal pain. Her pain level was between a 2 and a 4, which she was used to living with, pain with bowel movements, pain after eating. And it turns out that she had a certain tightness in her abdomen that prevented her from standing up straight, but we didn't know that until after we treated her. So her pain was between a 2 and a 4. Her abdominal palpation was +3 to 4 tender. So there were tender areas in her abdomen, especially the epigastric area, the right upper quadrant around the umbilicus, that were so painful and tender to touch, you could just barely lay your hand on it. The abdomen was firm, but it wasn't an acute abdomen, so it was good to treat her, but it was tender to even light palpation. So my treatment strategy was to get rid of the pain from the adhesions first, so you can tell when the treatment for the Crohn's is effective. They wanted us to treat the Crohn's, but until you get rid of the adhesions, you can't touch her abdomen and you had to see the scar tissue to appreciate how important that was. She had a scar up the middle from her pubic bone to just superior to her umbilicus. She had a scar on the left side diagonally where they took out the ascending colon. She had a scar on the right side, and they all went deep into the abdomen. It was quite tender and very resistant to movement. So the first thing we did was treated the abdomen for adhesions, and that was the precision care with contacts on the back and the abdomen. Basically, we started like we always do with 1377. And that ran for 10, 15, 20 minutes, and it got softer and softer. And then the small intestine became more prominent. The adhesions in the small bowel became more prominent. So scarring 13 and 22, 13 in the ascending colon. Even though the ascending colon was gone, 13 and 31 did a lot of good to soften up the abdomen. The left side of the abdomen was tight and tender. So what's over there? Scarring in the descending colon, scarring in the sigmoid. And if you think about how the anatomy is when there's this much bleeding and this much trauma to the abdomen. You're going to have scarring between the colon and the ovary, 7, the tube, 4. Once we got the upper middle part of the abdomen loose, it became obvious that there were adhesions between the rectum and the bladder. And this was supported by her report of pain with bowel movements, pain with urination. Then while we're kind of cruising around her abdomen, found adhesions between the transverse colon and the liver, the transverse colon and the gallbladder, 38, the ascending colon, the cecum. Even though the ascending colon and the cecum were gone, those frequencies produce softening. And no, I can't explain that. Some of you might be able to, but that's just, they were on the list, so I tried them and they worked. So it's a little confusing. And then the omentum, both the subcutaneous fat and the omentum were sclerosed. So you remember that adipose doesn't scar, it's sclerosis. So we did sclerosis in the adipose. We had just a precision care and a custom care that Wednesday in the hospital. So we were doing this treatment in the hospital, and we ran the concussion protocol, and I have SIBO on my protocol. So we ran a concussion protocol and SIBO. The scar tissue protocol took about an hour, and that's how long it takes to run these two. So then once the adhesions were gone, remember that her Crohn's started with an infection. So we did 61 and 22, 64 and 42, 64 and 63, the 2 frequencies for pus and pus encapsulated. And we'd already run SIBO, but I still went back and ran inflammation and allergy reaction. Torn and broken, I ran because her gut was pretty leaky. She had some food sensitivities. So that frequency I forgot. So you can put that in there. 124 and 22, torn and broken, that's good for the leakiness. We already did in the SIBO protocol, we'd already done 294 through 21 and 9, and then vitality and the small intestine. So at that point, the bloating was gone, all the abdominal pain was gone, and her adhesions were gone. Her posture was more upright. So when she stood up, she was literally 2 inches taller than she was when she lay down. One of her friends, who's a PT at the hospital, said, "You're so tall." And if you see her shirt, there's no abdomen there. And when she first came in, her abdomen was more prominent than her chest. So that was our outcome with that patient. So think about the reason that I did the scar tissue first. I did the scar tissue first so that we could tell by palpation when the abdomen was non-tender. So I could have treated the Crohn's first, but there'd be no point because you couldn't tell when her abdomen was non-tender because the scar tissue was causing so much pain. We probably also did scarring in the nerve and scarring in the artery. I'm pretty sure I did that. So add that to the list, scarring in the nerve, scarring in the artery. I'll modify the slides before we put them on YouTube. So if you make a note, I'll fix that. So that was that. And then, so that took us about an hour. And then the next patient they brought in was a 38-year-old patient who had had a stroke. She had a left cerebral stroke at age 35. So it was 3 years chronic, age 35, so it was 3 years chronic. And it was secondary to sleep apnea that was caused by adenoids. Stroke in a 38-year-old is really odd. So if it's not an aneurysm, so it wasn't a hemorrhagic stroke, it was an ischemic stroke. It's not an aneurysm, and is not a congenital vascular defect, it's going to be a stroke in that someone that age is caused by sleep apnea. And indeed it was. It happened early in the morning, and it was caused by adenoids and tonsils that were really huge. So she'd already had surgery to remove the adenoids and tonsils. It's nice to fix the stroke, but it's more important to prevent the next one. So they'd already done that. We didn't have to worry about it. She had sort of the classic right-sided stroke, left side of the brain, right-sided body problem. She had spastic paralysis in the arm and shoulder and hands. Her fist was clenched. Her arm was adducted. Her serratus and subscap were spastic. She could not raise her arm. She had no active movement on the right side. She had assistance at home, and she had the normal sort of swing your leg kind of gait with foot drop in her right leg, and a combination of spastic and mostly flaccid paralysis in the right foot. I don't know how to describe it except that it was characteristic of a right-sided stroke. She had sensory loss on her right side. She said it was like she had a glove all the way up her arm. She had no sensation on the right side of her arm or trunk. She had no facial paralysis, which was nice, and she had no difficulties with speech. So the treatment strategy, we didn't actually do many pictures during the treatment because I actually wasn't totally expecting it to work, but then it did. So the treatment strategy, what I was looking for was to treat the left sensory motor cortex strip in the cortex. So that exists in what we call 90, the frontal lobe or the cortex. But the sensory and motor strip, we have a frequency for 92. So the cortex is 90, but the sensory and motor strip is 92. So I wanted to treat the less sensory and motor cortex and increase secretions in that structure to alleviate the spasticity and the paralysis. So remember that the spasticity is caused by loss of descending inhibition, but the loss of descending inhibition is caused by loss of motor signal from the sensory and motor cortex. So the spasticity and the flaccid paralysis are kind of from the same source, which is you don't have input from the sensory and motor cortex. So precision care from neck to feet. She sat in a chair with a towel around her neck and a towel under her feet. And I treated trauma and paralysis and allergy reaction and inflammation, because strokes, even at 3 years out, are going to have a halo of inflammation that you want to reduce. And then increase secretions in the sensory and motor cortex. So we did 81 and 92, increased secretions in the sensory motor cortex for about 40 to 45 minutes. And then I figured we pretty much did what we can do. And then switched to 49 vitality in the sensory and motor cortex. And that turned out to be a surprise. We had the custom care running likewise from neck to feet. So we had both units from neck to feet, and the custom care ran the concussion protocol. And we also had 81 and 10 in my custom care because I used that to treat myelopathies. So we had 2 units in neck to feet. And so this is after about 30 to 45 minutes on 81 and 92, increased secretions. Her hand relaxed gradually. It took about 40 to 45 minutes, okay? So as it's relaxing, Kathleen Casbin, who's pictured here, is gently mobilizing the wrist and the hand as a physical therapist. Kathleen is a manual physical therapist for 40 years, 50 years, I think. She's 71, and she's been a PT since she was 21, so that's 50 years, I guess. So she's doing what a manual PT will do, which is gently, gently, gently mobilizing the wrist and the hand. And it was about 45 minutes into it that she could begin to mobilize the wrist and the hand. So we're at about the 45-minute mark now, and the patient can mobilize her own hand actively with her other hand. We wanted to reconnect the left side and the right side. So we had her move her right hand with her left hand so the 2 sides would be talking to each other, okay? We're still on 81 and 92. So I figured we were done. We've got what we've got. This is more than I ever expected. And so I moved to 49, vitality in the sensory motor cortex. Now, I usually do 49 just kind of as a drive-by, right? I don't expect it to do a whole lot. And 49 and 92 began to relax the shoulder muscles. So Kathleen Casbin started to gently mobilize the shoulder and the elbow as the serratus and the lats and the subscap and the shoulder muscles, the spasticity was reduced and they began to relax, okay? It was extraordinary to watch, and Kathleen is working very slowly. You can tell she's done this before, but without FSM, it's a very long and difficult process. If she increased the movement, so when she increased movement, if she moved it too fast, the hand would clench again and become spastic. So you have to bend that's going into the brain with the ability of the injured sensory and motor cortex to process it, okay? So you keep the movements in stroke patients very slow and deliberate, and that's that's why. When we moved it too quickly, her hand would clench. So we continued with unit number 1, running 49 and 92. And Kathleen was just stunned, and so were we all, when the patient's arm, she was able to move the patient's arm up to 180 degrees. Now the second unit is still running increased secretions in the cord to increase that, to push that descending inhibition of spasticity. So they had passive movement first, and then as Kathleen would lower the arm and raise the arm again, the patient was able to do active assisted motion into abduction and flexion. So it was the first time since the stroke that the patient had this range of motion, either passively or actively. So we finished up with 49 and 92 and 49 and 10, and we had this movement active assisted. Now you see where the two machines, one set of alligator clips and one set of gloves and this little towel around her neck. The other towel is down under her feet. So we took the machines off of her, and the patient on her own demonstrated almost full active range of shoulder motion. She lifted her arm up. She's in a little bit of scaption, so you can see that she's not moving the shoulder completely normally into abduction. But wow, it's active. She's ecstatic, lifting her arm over her head. And then she felt her arm and she said, the sensation is normal. The glove is gone. So she had normal sensation for soft touch. I got the pokey wheel out, and she had normal sensation for sharp touch, and she had normal proprioception. She could tell where her hand was in space. So that was pretty extraordinary. This is on the Wednesday before the seminar. So our flight was, we were headed back to Taipei and then back to home on Monday night. And I had to see her Monday morning to see what was left, because you really never know how much is going to remain. And so she arranged to come into the Frederick Lynn's clinic, and active shoulder range of motion was just what you see here. Both arms up over her head. Her hand is still spastic, so her hand is clenched and spastic. The sensation was present, but reduced. It was almost normal. It was about 50–60% of the other side. And the right leg was still flaccid and spastic, flaccid with a foot drop. So she had that swinging gait that you get. It's actually more flaccid than spastic, I guess. Anyway, so she's still walking as if she had a stroke. So we began as before with two machines with the contacts at neck of feet. And then ultimately, when Kathleen started working on the hand, we moved one unit to from the foot up to a contact that's under her hand. So this is her occupational therapist that is assisting. This is Kathleen working on her. Then the OT got her hands in there to see what it was that they were working on. And then the second machine was running the concussion protocol neck to feet again, and then 81 and 10 while they're reducing the spasticity. And then while they're starting to move the arm and the shoulder, it occurred to us that the nerves and the dura were probably scarred up in the neck. So we added 13 and 443 while we were doing neck movement. I just basically had her turn her head from side to side. So it was frustrating. We needed additional assistance with motor secretions to reduce the spasticity and improve active motor function. So I had a text message that gave us the frequencies from the advanced for the brain motor centers. I hardly ever use them, so they're not in my head. I don't remember them. So 245 and 415, of the four of them, those were the two that did the most. And we did 94, increased secretions 81, and vitality in 415 and 245, the motor centers. And that further freed up the wrist and the hand and the shoulder. I tried 253 and 255, and that little squiggly sign is for not so much, didn't do much. And the treatment basically worked. As Kathleen is working on the shoulder, look at the movement she gets with 415. When we added 415 and 245 with 81 and 49, the active range of motion, her elbow was up behind her head and completely loose and relaxed in the trunk. Sensation is completely normal. The right hand still tends to clench with movement. So there's a piece of the damage that's in that homunculus that's specific to the right hand. So we left the occupational therapist and Dr. Lim. This is me and Kathleen and her daughter Katie who took the pictures. The plan for regaining active leg movement and hamstring motion. These are the more difficult in stroke patients in my experience. Somewhat limited experience, I might add. Contacts at neck and feet. Dude, trauma, torn and broken, 81, maybe 13 and 49. Oops, I forgot to put 49 in there. With 92, the sensory and motor cortex, 415 and 245, the motor centers, and then 988 is the basal ganglia. And the question marks are there is because I'm not sure that the basal ganglia are going to be essential, but I think they will be in coordinating that movement. And then you need a second machine going down the spinal cord with 81 and 10. And then there's a peripheral issue with that foot. See the spasticity in the toes? See that down there, that big toe that's clenched, okay? 81 and 10 will reduce the spasticity. 81 and 396 will drive the impulses from the sensory motor cortex and the motor centers down the cord, down the nerves. 46 is the frequency for the muscles, and 84 is the cerebellum. When you're doing 81 and 84 and 81 and 92 and 49 and 92, 81 and 49 and 84, you have the patient standing up and doing little knee bends and rocking from side to side. And I believe it's going to be possible in 3 to 6 months to restore normal movement to her leg for gait, at least get it closer to normal. And I'm not sure what's up with the hand, but every time she has more motor input, the hand starts to clench again. Now, it's not as bad as it was, but it's still starting to clench. That's probably going to be scar tissue in the sensory and motor cortex up here that we might need to get rid of. So I'll modify the slides before we post them on YouTube and send them out. It was a happy day. We were all having a good time. Okay, so then when we did the core seminar, the second weekend of the core seminar, we had patients come in to be treated on Friday, Saturday, and Sunday. The patient on Friday was a 68-year-old man. His complaints were a red, scaly face with a skin rash that he had had for 10 years. And his face, it wasn't rosacea, it was dry and scaly. The official medical diagnosis was eczema. It's basically red, scaly face skin rash. It's the only place he had the rash was on his face. So, and then the Parkinson's complaint was 8 years chronic. So the physical exam was done by the neurologist. This is Su Ming from Rutgers University. She flew over to Taiwan to take the course. She's a pediatric neurologist, but she knows how to do an exam for Parkinson's. So she did his reflexes and tested. He had cogwheel rigidity, at least at the elbow and wrist. He had a fine tremor in both of his hands. I think it was worse on the right. He had a shuffling gait. So this is characteristic of Parkinson's when they can't lift their feet. So they have the shuffling gait. When they turn, they have to turn their feet both together. He had a lack of facial expression, the facial mask that is characteristic of Parkinson's. And the skin on his face was very red, very dry, irritated. There weren't welts on it, but it was very red and dry and scaly. And nothing they did to it helped, and most things made it worse. So the treatment strategy, my understanding of Parkinson's is that it's usually associated with toxicity exposure. So there's that documentary called The Frozen Addict from the 70s. And that was my first information about Parkinson's. It says that it's something like 90% of Parkinson's patients in Canada are from farming areas. So I asked him if he had any exposure to organic chemicals. Was he a farmer or a painter, or did he work with organic chemicals? He said, no, I'm a teacher. But it turns out that his school was next to a chemical factory. So that's where his toxic exposure was. His wife was there as a translator because his voice was very quiet and hoarse. Parkinson's patients have trouble with motor activation of the vocal cords and the muscles in the neck. We had an auto care, and we put the skin allergy in the skin section, the skin allergy protocol. Context is behind his neck, and then barbershop fashion over his face. So it covered the whole rash, but we kind of kept it away from his eyes, because when we started it, he said he could see flashes of light when the current flashed, so we moved the contacts away from his eyelids so that wouldn't bother him. Then Parkinson's was on the precision care with the contacts around his neck and under his feet. So 988 is the frequency for basal ganglia. I ran the frequency for 94, trauma. I know I should have run 970, but I usually skip it. 94, 321, and 9. I did 40. I did 124, left those out. And then 57, 900, 920. And 57 and 920 made him completely stoned. He just went away. Glassy eyes, didn't drool, but couldn't keep his eyes open. 900 was okay, but not as profound. And then we did increased secretions and vitality in the basal ganglia. We had to have him drink water. We asked him, are you hydrated? How much water have you had today? He said none. So this was, I don't know, 3 o'clock in the afternoon. So we drank about a quart of water before the treatment. And then we treated him for about an hour. And I asked him what medication he took. And his wife went to the computer and they put in a number from the state health insurance scheme, and she printed out a list of his medications. So he got up off the table, walked to the bathroom, and his gait was not shuffling. He walked completely normally. While he was in the bathroom, we looked at his medication list, and there were 2 neurologists in this class, one from Taiwan and one from the US. And all 3 of us looked at this medication list and just it was appalling, just appalling. Massive doses of levodopa, carbidopa, Requip. So they were stimulating both dopamine production from the basal ganglia, dopamine agonists and receptor agonists, so that they were pounding dopamine, and just the medication was intense. So he comes back from the bathroom, and the skin rash was almost gone. His skin was pink, not red. There were no scaly places. It was no longer uncomfortable. It was completely normal. He sat down on the table, and his voice was normal and strong. His wife said, "Oh, his voice is louder. Usually I have to interpret for him because nobody can understand him." And his gait was normal. The shuffling gait was gone. Dr. Ming repeated the physical exam. The cogwheel rigidity was gone. The tremor was gone. And when he went back out into the waiting room area, I walked out to see how he was doing. And oh my gosh, he had the most brilliant, wide smile. His face had wrinkles. He had a big grin on his face, and he was moving his eyebrows when he talked. The mask was gone. Now, there are people there who can treat him, and this protocol is always going to work. But we have a problem. The long-term plan is difficult. He needs nutritional support, which apparently in Taiwan is strategically difficult because the doctors aren't used to where to get the supplements. They aren't as widely available, and they're not as widely used as they are in the US. The supplements for Parkinson's are for the mitochondria in the basal ganglia. So you want CoQ10, 400 milligrams a day. You want lipoic acid, 100 milligrams a day. You want vitamin E. You want vitamin C. Everything to support the mitochondrial detoxification system in the basal ganglia, and you want essential fatty acids. So that needs to happen. The biggest problem we have actually is that his medication makes it possible for him to move, but it's going to cause the disease to progress much more rapidly. So I don't know if FSM is going to be sufficient to keep the progression at bay. Dr. Lynn is going to have to figure that out because the patient will be back to see him. The FSM treatment is possible, but it has to be integrated with nutritional support, and that is tricky. So I'm going to make a separate slide for this long-term plan that includes the supplements that he needs to take. So that was really fun. His smile, I wish we got a picture of his smile. There's no way to tell you about that except that it was just amazing. So remind me to make that slide. Okay, so then on Saturday, we had 2 fibromyalgia patients. The first fibromyalgia patient was Mr. Sung, and it was fibromyalgia that didn't start out as fibromyalgia. He is 59 years old. 10 years ago, he had probably an otolith displacement. We don't remember, he doesn't remember why, but he had dizziness that lasted for 3 years, starting 10 years ago. Ultimately, he was diagnosed as BPPV. They had no treatment was offered, and he just kind of got over it. Somebody did the Epley maneuver and some other things worked, and he was dizzy and disabled for 3 years. And he stopped sleeping. At the end of 3 years with no sleep, his body pain started. So we had just gone through the mechanisms of fibromyalgia, and you know that during sleep, during deep sleep, you have growth hormone produced. If I took anybody listening to this webinar and I stopped you for sleeping deeply for 2 years, and you know that if you're dizzy, lizard brain is not going to let you sleep or sleep deeply. He's going to wake up every 30 to 60 to 90 minutes. You won't get deep sleep. You won't get growth hormone. When you don't get growth hormone, you get body pain. And when you get body pain, the whole neuroendocrine cascade that goes into effect with fibromyalgia goes into effect. It's not negotiable. So the dizziness was gone, but now he had body pain, and he was diagnosed as having fibromyalgia. So his physical exam was interesting. His reflexes were normal to reduce. They were really slightly reduced, +1. So he wasn't a cervical trauma fibro patient, okay? His sensory exam was normal, and he was sweating. The hair on the back of his neck was dripping, his face was wet, and I noticed he wore a towel around his neck to absorb the sweat. Then I asked him what his pain level was, and he said, it's a 2, a 1. And I said, are you on medication? And he said, yes. My last dose was 90 minutes. He takes pain medication. I said, when was your last dose? He said, 90 minutes ago. So his pain level was 1 or 2. And it turns out on opiates, his usual dose is every 2 to 4 hours. And he gave us his, and looked it up on the computer. And the medications were once again distressing, alarming, excessive. Wow. He was on multiple opiates, plus tramadol, plus an antidepressant, plus gabapentin. During the physical exam, he would nod off and fall asleep in between commands. So asking him to move his arms or whatever, he'd wake up, but he was nodding off, sitting up. It was sort of typical of opiate overdosage. I don't know what you do with a medication list like this. His digestive system wasn't great. He was constipated, but on the kind of opiates he was on, that's not surprising. He had food sensitivities and reactions. He didn't sleep well. He was cold all the time, so he had the reduced thyroid that you find with fibromyalgia. Oh my gosh, it's 4:45. I gotta go. Where are the number of slides? Oh, there they are. Okay. So this is Mr. Sung. During the assessment, Kathleen and I are talking about what to do with him. We just hooked him up back to abdomen. I had no hope. He had no pain, so there was nothing to treat. I had no hope of addressing the fibromyalgia, but I hoped to make him feel better. He was such a sweet man. So we put the contacts on the back and the abdomen and deal with the excessive opiates and their side effects and deal with the original dizziness. So we set up 2 machines on the back and abdomen and dealt with remove anesthesia, and the opiates 43, 46, and 4, morphine, from the nervous system 45, the liver 35, the cortex 90, and the midbrain 89. We did 40 and 89 for the central sensitization, and then we did concussion protocol, and Kathleen did the 970s. So Kathleen Casben did the treatment while I went and started with our other fibromyalgia patient. So this is Mr. Sung, how we set him up. It was neck, he was back and abdomen. He's not a 40 and 10 patient, so he wasn't set up from neck to feet. So the outcome at the end, he was no longer sweating. His pain wasn't even a 2. That was good. His head was more clear. He was happier, felt really good, and he was very difficult. The long-term plan for him is difficult. He's not likely to recover. I'm used to getting fibromyalgia patients better, but I told the class of 23 practitioners, you're not going to get this guy better, not with the medications he's on. So what I recommended was to treat him once or twice a month, unless his physician decided to change his medications, unless he changed medical physicians and changed his own discouragement. He'd been sick for 10 years. That's a long time. So that, if that changes, then it's possible. So what I suggested was have him come in once or twice a month, be his friend, give him someone to see. He is isolated. He is kind of depressed. Give him some relief, give him hope, and perhaps guide him into a healthier life. Do what you can. Even if you can't get them to a cure, you can still get them to improvement. So this patient, they both came in at the same time. So this patient is a 32-year-old male. He had body pain and muscle tightness since age 5. It is unusual for a fibromyalgia patient to complain specifically of muscle tightness. Body pain, we're used to, that's 40 and 10. But this was muscle tightness. His onset since age 5 was a febrile seizure that lasted 2 hours. He started having the seizure because his temperature was 104, 105. Parents took him to the clinic. The clinic wouldn't help them because they didn't have the facilities, so they had to take a bus to the hospital in the next city. It took them 2 hours. So this seizure lasted 2 hours. So after the seizure, he had body pain and muscle tightness. Okay. So our neurologist did his reflexes. They were hyperactive. He had 1 to 2, 3 beats of clonus. He had sensory hyperesthesia at almost every level. So the allodynia was accompanied by sensory hyperesthesia. His pain level was a 5 out of 10. He takes no medication. His pain does go up to a 7 or an 8, goes down as low as a 4, but it's there. His muscles, when you see his picture, they're toned, but they're very tight. He lifts weights. So you can see his chest muscles and deltoids and biceps are very well developed. And look at his adductors and his quads, okay? So this is us assessing his muscle tone. And when someone has loss of descending inhibition, the place you're going to notice it is the adductors and the pectineus and the quads, and then around the back and the hamstrings. So we set him up. The body pain is 40 and 10, but when they have muscle tightness and loss of descending inhibition at the same time, you have to do both machines at once, or when you run 40 and 10, the tightness is going to get worse and it will create its own pain. So you have to run 2 machines at one time. We had 40 and 10 from neck to feet to reduce the pain, 81 and 10 to reduce the tightness, and then 40 and 89. Once the pain was down to a 0, I switched the 40 and 10 machine to 40 and 89 so he could get used to being out of pain. He's 32. He's been in pain for 27 of 32 years, since he was 5. The third machine was on his back and his abdomen, treated for concussion. And we ran, once concussion protocol was finished, we ran 40 and 89 back to abdomen until the neck to feet machine unit could be switched to 40 and 89. So my theory, why I picked this treatment strategy, is that the seizure either injured his neck and spinal cord from whipping it around, or possibly a seizure that prolonged can injure the brain and the spinal cord. So I really didn't know if it was going to be thalamic, 40 and 89, or the cord. So the only way to tell was to treat the cord and see if that did it. If 40 and 10 didn't do it, then you'd go to 40 and 89. 40 and 10 took his pain down, so that was good. Causing cord-mediated pain and loss of descending inhibition that created the muscle tightness. So this is the plan. So we ran 40 and 10 neck to feet for the pain, 81 and 10 increase that descending inhibition to reduce the tightness, and then 40 and 89 for the brain sensitization. And then a second machine back, third machine back to abdomen to run the concussion protocol, you know, because you should. So one of the things that happened with him was when his pain got down to a 0 to a 2, He was so stoned, he lost the ability to speak English. You can see his muscle development. I don't know, you can't tell from the pictures, but his arms are relaxed and flaccid. His legs are relaxed. The muscle development is still there from all his bodybuilding, but his arms are flaccid. They're relaxed. It was amazing. And he was completely stoned. Pain was reduced in about 60 minutes. The muscle tightness was reduced. The muscle was still toned, obviously, but relaxed, even the arm muscles. And we were asking him questions about what he was experiencing, and his speech was slurred. He said, I can't speak English. So he spoke English and Mandarin equally well, and he got so stoned he couldn't speak English. So at the 70-minute mark, I asked him, so his pain was a 0. I asked him how he felt, and he said, I don't know. Now, think about that. I don't know how I feel. Why doesn't he know? I mean, think about it. Why doesn't he know? He's been in pain since he was 5. His body sensations have stopped in his thalamus pain centers since he was 5. I'm not entirely sure that his sensory cortex was connected to his body. So we switched the 81 and 10 machine to 81 and 84, and I had him start moving his feet and his arms so we could drive the motor coordination from the cerebellum. But we switched the 40 and 10 machine to 81 and 92, increased secretions in the sensory and motor cortex. And we drove the sensory and motor cortex to reconnect with his body. So he's moving his feet into, what do you call it when you have them point your toes? Point your toes down, bring your toes back. So he's plantar flexing and dorsiflexing his feet, and he's moving his biceps and like he's doing biceps curls. So he's moving his arms, he's moving his feet, and we're running both increased secretions in the cerebellum and increased secretions in the sensory motor cortex. If we tried to stand him up, this is all happening while he's laying down. This is all happening when he's like this. If we tried to stand him up without reconnecting his cerebellum and the sensory and motor cortex, I wasn't entirely sure he'd be able to stand up. So once we finished that exercise, his pain was a 0, he could move. I asked him how he felt, and he said, I don't have any pain, I feel okay. So I sat him up, and now this is the projector in his face, but he's still incredibly stoned. The endorphins were so high. So fibromyalgia, this body pain and muscle tightness patient, the key to his treatment was to wait. Right? You're rewiring the nervous system. Wait for the pain to come down. That was 40 to 60 minutes. Wait for the muscles to soften. 40 to 60 minutes. Wait to find out how he feels. Wait while you think of what to do next. I'm sitting there waiting while I figure out that I better run the cerebellum and the sensory and motor cortex, or he's not going to be able to stand up. And you have to wait for this process because treating and rewiring the nervous system takes time, and that's what you're doing. So I've never run a video before, so I'm hoping this is going to work. After the treatment, we had to teach him to walk again so that he could learn to use his new muscles. So this is him walking, toe, heel, toe, heel. Look at how easily his legs move. Look at how loose his arms are. Once you get him reconnected by having him walk like this, it's done. You don't have to do it again. The endocrine recovery process was to keep the pain down to a 4 out of 10 with follow-up treatment as needed. Dr. Wang is going to do that. This gentleman is a physiatry resident. He went through medical school with his pain level at a 7 and with spasticity in all the muscles in his body. And he is a resident. He works at the hospital with Dr. Wang. And so the two of them will keep his pain down and this young man will recover. That was really like so much fun. Okay, the last patient is a 22-year-old male who was burned 3 years ago. Young man, he was 19 when it happened. He was at an amusement park. And this flash powder that they used something went wrong, and this cloud of flash powder exploded, and he was burned over 40% of his body. His face and his chest, torso were okay, but his shirt caught fire. His arms and his hands were burned. Legs and his feet were burned. His shoes caught fire. He had autografts. There were no cadaver or porcine grafts used, so the scar tissue actually was not as bad as it could have been. He had no graft infections. And so this was kind of a best case scenario. And he had no pain and no itching. So he had no denervation from either the burns or the surgery. This is a great gift. So that was pretty cool. But the limited range of motion was the most bothersome in his right arm. So that's the only thing we undertook. We just had him for an hour during this demo at the seminar. When we took his shirt off, and he has compressive garments. I don't think we got a picture of his garments, but where's my pointer? There we go. They took his grafts from his trunk. On the torso, he tends to form keloids. So at some point when you're finishing up with him, you're going to have to deal with the keloids. He has burn scars on both legs. His feet and his toes are worse, but this is the scar on his arm. The wrist, you can see there's a band there. The graft on his hand is scarred. I didn't get a picture of that, but this was the most dense. You can see how thick it is. It's very thick, very dense, and it restricts the movement at the elbow. So this was the most bothersome for him. For burns patients, it's just slogging. It's just mobilization and manual therapy. Do the 58, 00 doesn't do much, 02, 32 did some. Scarring in the skin, 355, but the skin is made up of connective tissue, 77, 142 is the fascia underlying, and then the blood supply. And then sclerosis in the adipose in the subcutaneous fat. Mobilize the tissue while you're treating. Feel for any softening and move the fingers into the softened area. Repeat. So I did roughly the same thing in the same area, opening up his elbow. Each time we had contacts above and below the burn area. So there was one towel down around his hand, and I put this towel over the burn. The other contact was up at his shoulder, where there was burn scars too in his axilla and along the deltoid, but I didn't get a picture of that. Mobilize the tissue while the frequencies are softening. It took 60 minutes. And here's a video of the movement that you do.
This coloration will change as his motion improves. And
so you can see I'm not being gentle. I'm moving his wrist fairly firmly. My fingers are digging in. He has no pain. The nerves are not adhered. And I kept the towel under my fingers while I'm moving it, and grabbed that big lump of scar tissue in his cubital fossa.
How many surgeries?
He had 6 or 7 surgeries, I think he said, but none of the grafts failed. So that's the movement. I started out gently, but you can see that the scar tissue here is already thin, and I'm working on that dense spot in the middle. The treatment plan was for Dr. Wang or Dr. Lin to follow up, and it would take 12 to 18 follow-up treatments on the arm, the other arm, additional body areas, work on one area at a time. And then once the scar is reduced, see if the physician who's managing his compressive garments will allow him to stop using the compressive garments. So that's what it looked like at the end. I don't know if you can see it, it's hard to see, but his elbow is more flat. That big dense glob of scar tissue is flatter, it's not gone. This is lighter, thinner. The range of motion in here was much better. The shoulder is going to be its own job. So this is like 3 to 6 months worth of work once or twice a week, whenever he can afford to come, whenever they can treat him. It's not going to grow back. The scar removal is permanent. The range of motion will remain. So they can help him regain his range of motion. The toes are going to be the hardest. I don't expect those to improve because the cartilage in those little teeny joints gets cooked, literally. And so you lose joint mobility. It's not just the joint capsule, it's the cartilage gets cooked. But they'll be able to get his ankles normal. He's back in sneakers, so he's not in braces. So they should be able to improve his ankle range of motion, and that will improve his gait. So just a reminder of what we do. It's all resonance. Drugs and nutrients are like keys, and the frequencies are like that key fob opening the same lock for a signal. With a signal. I encourage you to use this metaphor with your patients. You're changing cell signaling and function the way a drug changes the way cells work by a key and a lock. You're changing the way cells work with a key fob. This is a metaphor that most patients can understand. If you go back to all of those cases, fibromyalgia, the Parkinson's patients, you change the pattern in the tissue. We had to treat toxicity. We had to treat the sensory cortex. We had to treat the cause of the problem. And then you still have to support the stable state with nutrition and exercises. We had to teach Johnny, the fibromyalgia patient, to walk again. We had to support the stable state in the motor system by connecting his cerebellum and his sensory cortex to his body, okay? Just a reminder about the FAQ brochure. It's updated information, it's current, it's easy to read. We sell them pretty much at cost. We don't mark them up much. I'm happy to send you the file if you want to try and get them printed yourself, but we sell them for, how much do we sell them for?
So it's $40 for 50 and 75 for 100.
Okay, it's $40 for 50 and 75 for 100, and I can tell you we don't make any money on those. So give them out. So it's important for your patients to know what you're doing and why. The practitioner list subscription program is coming along. We're almost there. It seems to be one computer website glitch after another, but they keep putting in plugs and fixing it. So it's coming, I promise. It'll be $89 a year, but we have to do something to keep the practitioner list accurate and up to date. Patients will call, read the book, The Resonance Effect. They'll call to find a practitioner and they find 3 people that are dead or retired. So somehow we have to get the practitioner list accurate and up to date and make sure that you are on it. There will be a yearly auto renewal, $89 a year, and you will make that up on the first patient that calls you. I am told that patients do call. The magnetic converter, just a reminder about that. It's incredibly convenient for worm care, for home treatment, for long treatments, PTSD and postoperative care where you don't want sticky pads or wet anything in the hospital bed or at home. Just a reminder, there is a $1,000 publication prize. Jody Adams won it this year and you can win it next year. If you publish a case report in any peer-reviewed journal, it doesn't even have to be abstracted. It's nice if it's indexed so people can find it on the internet. You can take home a $1,000 prize. There is no limit on the number of prizes per year. This is the best way to get FSM documented, and this was a simple case report involving chronic pain and adhesions after ulnar transposition surgery. It was easy to write. Send a friend to the core and get a referral bonus from Precision Distributing if they buy equipment. We're in Philadelphia in June. Join us there and send a friend. We're in Denver in July, 26th to 29th. Send a friend. We are in London. If you want a trip to the UK, or if you know any practitioners in Ireland, in Europe, or in London, come to the core seminar September 13th to 16th. It's being sponsored by the Osteopathic College, or it's being held at the Osteopathic College in London. We'll be in Jacksonville, October 25th to 28th, Minneapolis, November 8th through 11th, and San Francisco, December 6th to 9th. So this is what you guys are doing. I swear you are changing medicine one patient at a time. We did that in Taiwan with these 6 patients, and you are doing it at your home. Changing patients' lives, when we do that one practitioner at a time, that happens every time you treat somebody and change somebody's life. It makes me really, really happy that you're an FSM practitioner and you took the seminar and are using it. And just imagine what changing one life can do to change the world. What was that stroke patient going to do? What are those pain patients going to do when they're out of pain and their lives change? Okay, the Parkinson's patient, is that Parkinson's disease patients? Yeah. Those frequency of FSM, the frequencies are listed on the slide. We were treating the basal ganglia at 988 and treated for trauma and scar tissue and whatever. We did the toe heel gait. This is another question that came in from Marilyn Miller. The normal gait, his cerebellum didn't have any idea how to move, how to connect with his peripheral body. If he walked heel toe with a normal gait, cerebellum already knows what that's about. So it ignores input from the body, the proprioception. It will regulate the gait as if the muscles are still tight. So you shift the gait. We call it engramming because that's what I was told it was called. I don't know if that's what it's really called, but you shift the gait to toe heel. So it's a new pattern. and the new length and tone of the muscles is integrated into the nervous system. And length and tone of the muscles is integrated into the nervous system by toe heel walking. And then once it's normal, once his balance and once his brain knows what the length and tone of those muscles is, then he can walk normally and it'll be just fine. So we will post these slides. I'll make the changes. We'll post them on YouTube, and Kevin will send them out.
Yep.
Kevin will send them out. We'll post them on YouTube, and we'll talk to you next month. Have a good one. Keep doing good things. Talk to you soon. Bye.